I'll be presenting a case whose name XYZ, 72-year-old male. Is a retired teacher, and he's from Dharwad. Admitted on 27th of September and examined on 18th of October. Right-handed person, and informant is patient self and wife reliable. Presenting complaints, he came with a history of left lower limb weakness since 1 year, right lower limb weakness since 8 months, and complaints of bilateral upper limb weakness since 4 months, and difficulty in speech since 1 month, and fever and breathlessness since 5 days. History of presenting illness. Patient was apparently alright before 1 year. Later, when he developed weakness of left lower limb, which was insidious in onset, gradually progressive in nature, patient initially noticed that he was tripping while walking, which was 3 to 4 episodes of tripping in a 10 days duration. Later, after 15 days, he noticed foot weakness in the left lower limb, and he was not able to grip his slippers, and there was a slippage of slippers while walking in spite of patient being aware of that. Weakness gradually progressed over the next month. 1 month, he had developed difficulty in getting up from the squatting position, difficulty in climbing stairs, and during initial period he was able to walk with the help of support of walking stick, but later 3 months later he required the help of crutches to walk. And he also came with a history of weakness in the right lower limb since 8 months, which was also insidious in onset and gradually progressive. He initially noticed that he was not able to grip slippers and slippage of slippers while walking, in spite of being aware of it. And he was initially using Indian commodity. Then later he had to switch to the Western commodity because of he was not able to get up from the squatting position. Since past month, 5 months, he's a bedbound and is not able to lift his leg. And also there's a history of difficulty to roll over in the bed since past 5 months. Uh, Also complaints of bilateral upper limb weakness since past 4 months, ma'am, which was insidious in onset, gradual progressive. Weakness started as patient initially he was not able to mix his food, not able to button and unbutton his shirt, not able to hold the glass of water. And later it progressed to that extent that he is not even able to comb his hair, lift his arm above head, and had a difficulty in wearing shirt since past 1 month. Patient's wife.
Yes, ma'am. I am not hearing now. Hello?
Yes, ma'am. Yes, ma'am.
Now it is audible. I am not hearing. What happened?
Ma'am, I think sir is having some audio problem.
Okay, okay.
Patient's wife initially noticed. Patient wife, can I? Am I audible?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Patient's wife noticed fine involuntary twitching movements over arm, leg, and fingers, ma'am, which aggravated on touch and movement and flickering of water. And patient's wife also noticed there was a thinning of both upper and lower limb. Patient also complained of difficulty in speech since past 1 month, which was insidious onset in such a manner that he had a difficulty to initiate the speech and he has to strain while speaking. But patient was able to understand the words and respond back to the commands. No history of change in voice quality or nasal regurgitation. Fever since 1 week, sudden onset, high grade, associated with chills and rigors, continuous type, and was subsided slightly on taking paracetamol tablets. And also complained of breathlessness since which was sudden in onset, gradually progressive, increased on exertion and delayed on rest. No history of chest pain, excessive sweating, cough, palpitation, orthopnea, PND or wheeze. No history of backache, no history of bowel or bladder disturbances, no history of headache, vomiting or altered sensorium, no history of diurnal variation, no history suggestive of higher mental function involvement, no history suggestive of other cranial nerve involvement, no history suggestive of sensory system involvement or cerebellar and autonomic system involvement. Past history, patient is a known case of hypertension since past 4 years and is on telmisartan 40 mg OD compliant with the medication. No history of pulmonary tuberculosis or CV or diabetes in the past. Personal history is appetite and sleep is normal. Bowel and bladder habits are normal. Non-alcoholic, non-smoker. Family history nothing contributory. Born of non-consanguineous marriage. Course in the hospital, there is no improvement in his neurological status since he got admitted. But when he came, he had a respiratory distress in view of which he was intubated and he was later tracheostomy, and now he is on tracheostomy with oxygen support. Presently, he is bedridden and is dependent on his wife and son for all his daily routine activities. Summary. uh, Elderly male hypertensive patient presented with slowly progressive pure motor symmetrical quadriparesis, lower limb more than upper limb, with truncal muscle weakness, with wasting, with fasciculation, dysarthria, and without sensory cerebellar bowel and bladder dysfunction.
Okay, we'll start analyzing the symptoms now, one by one.
Yes, ma'am.
You told he is a right-handed person, no?
Yes,
How did
ma'am.
you decide, ma'am?
Ma'am,
How did you decide?
Ma'am, right-handed person, when we ask him to catch something, he is a right-handed, ma'am. He writes with right hand. And whenever we ask him to catch him something, whenever we give something, he was bringing his right hand front, ma'am.
Okay, we have done this exercise many times. Still, it is important in some situations.
Yes,
So, would you
ma'am.
like to tell me what all methods you are supposed to use? He is a teacher. He would have written with the right hand only.
Yes,
So,
ma'am.
what all methods you are supposed to apply when you
Yes,
do
ma'am.
a scientific presentation? Because in some situation it has got relevance, handedness. No.
Yes, ma'am.
So, what all questions you are expected to do? This is only revision. We have done it before. You
Yes,
tell
ma'am.
me, ma. What all things will help you to know it is right-handedness? You said that he writes with the right hand, and
Yes,
he
ma'am.
was bringing his right hand when you offered some object.
Yes,
Okay,
ma'am.
agreed. Tell
Yes.
me, with that we cannot go ahead with an epilepsy surgery or tumor surgery on the left side and say that you will not get aphasia. No.
Yes, ma'am.
So what all things you are supposed to do, ma? To
Uh,
know the real handedness, one, you will look at the eye-edness. I have told
yes,
it previous
yes,
sessions, eye-edness, because normal, that is about 90% of the population is
yes,
right-handed,
yes,
right-eyed, left-eared, left-footed. The dominant foot is left,
yes, ma'am.
dominant ear is left, dominant eye is right, and dominant hand is right. So handedness we shift by our culture, and he is 72 years old. At that time, the people will shift. They have a tendency to think that left-handedness is wrong. So that era is over now still. So he is 72. So you have to look at the eye-edness.
Yes, ma'am.
So you tell the patient to focus on an object with your illuminoscope, which you used to do trans illumination in swellings, no?
Yes,
That
ma'am.
illuminoscope or something like that, kaleidoscope, something you give, and then which eye he uses. That's the simplest bedside test to know handedness. So eye-edness and handedness go together. Second, you can hold both hands like this, no? The
Yes.
dominant hand, dominant thumb will be down.
Okay.
Reflexly, consciously you should not do. Reflexly do, dominant thumb will be down. Or if you put your hands behind, the dominant hand will be up.
Yes.
So those are things which you can modify if you are a medical person, otherwise eye-edness. Then you apply next level, apply, what is that inventory called? Edinburgh's handedness inventory.
Inventor. Yes.
Two inventories are there. One is 10 point, another one is 21 point.
Yes.
The 10 point is for routine purpose, simple
Yes.
situations. 21 point is pre-operative. No?
Yes.
Of which 80% of the questions point to one side, that is the dominant side.
Yes.
Next, you can go for the EEG.
Yes.
EEG will show less well-formed alpha rhythm on the dominant side.
Yes.
Alpha is a rhythm of relaxation. So well-formed alpha means dominant side or non-dominant side. Poorly formed, poorly modulated alpha is non-dominant. That is the EEG. These are non-invasive simple tools you can do. And olden days, people used to do intracarotid amytal test. You do the carotid angiography and inject short-acting phenobarbital into the carotid artery. Patient will be counting and stretching both his hands. And
Yes.
when it is injected into one side, the opposite hand will come down. That means you have injected into the carotid only, not into the soft tissue. And when that hand is coming down, if the language stops, we are telling the patient to count. If the speaking stops, that is the dominant hemisphere. So when you are injecting into the right carotid, if the patient's left hand is coming down, it means you are correctly in the carotid artery. And if counting also stops, that means that side's language is on the right side.
Yes.
That is intracarotid amytal test. It is not now, nowadays it is not done. You can do the PET scan. So higher thing, you can do functional imaging. When the patient is given some task like communication, which part of the brain gets activated, that will be the dominant. So these are the methods by which then you can see the angular gyrus. The simple MRI, voxel-based morphometry, the volume of the angular gyrus is larger on the dominant side. So that is non-invasive and less costly. Voxel-based morphometry, we call it as. That way you can check. Or if you want to do PET scan, if you are in that situation, you can do a task-based PET scan and see whether which side is activated during language activity. So these are the methods. At the bedside, you should say eyedness, not that he writes with the right hand. Or you need not commit handedness if that case it is not relevant. But if you are telling right-handed, you should tell, I checked the eyedness. Eyedness, he is checking with a right eye, so I think it is right-handed. So that is the first thing. Second, you told that he was tripping. The first thing we started was tripping. No?
Yes.
So tripping means, what does it mean to you when somebody is telling tripping?
Used to fall.
It means that he is injuring his toes.
Yes, ma'am.
The word tripping is used when a person is falling due to injury to the toes. That means he has a foot drop.
Yes.
Dorsiflexion weakness. You understand? Somebody is tripping means he is injuring his toes while walking. Normally we don't do that because we start our gait with a heel. All of us start our walking with a heel, not with a toe. You can watch your walking tomorrow. When we start walking, it is a heel that comes to the floor first. The gait starts with the heel strike. So this person is tripping means instead of his heel strike, it is the toe strike. So there is a alteration in his walking pattern. Normal walking pattern starts with the heel strike, whereas my patient's walking has shifted to toe first. That means he has developed a foot drop. He is unable to dorsiflex and put the heel on the floor. So first thing you will say, my patient is tripping. So gait semiology has changed from the heel first gait to toe first gait. That means there is a foot drop. Okay, so the first symptom indicates there is a foot drop. So now you want to know whether the foot drop is due to, so that is how you will expand this symptom. Instead of saying gradually progress, you analyze that symptom. Is that toe first gait with a flail dangling toe? Or is it a stiff circumdecting toe? Or was it a continuously twisting? Because you can have LMN weakness for foot drop, you can have UMN pyramidal foot drop, you can have dystonic foot drop, and you can have foot drops due to contracture. That is not applicable in this patient because it is not there before and it came now. So contractures are not applicable now. So it's an LMN toe first or UMN toe first, or is a dystonic foot drop.
Yes.
So when you tell that symptom, my patients started tripping, you should tell that I asked him, he said that his feet was flail and it was hanging loose. Because of that, his injuries were getting, toes were getting injured. Then you know that it is a lower motor neuron.
Yes, ma'am.
If he said that his limb was slightly stiff and he could not lift his toe, that you know that it is an upper motor neuron.
Yes,
and
ma'am.
if he said that when he tried to put his foot forward, the leg was continuously twisting, it indicates that there was a foot dystonia. So these are the three situations where the people change their semiology from a heel first gait to toe first gait, which makes them trip. So
Yes.
that information you have to gather in a history like this. Then we will know whether it is LMN, UMN or dystonia. If it is UMN, generally pyramidal tract due to pyramidal foot drop, or extra pyramidal tract, that is dystonia. Whereas if the person says that my leg was flail, I was landing on my toe and falling, and I had sensory loss, I felt that my leg had become now numb, then you know it is either in the sciatic nerve, common peroneal nerve, S1 root. So all these are lower motor neuron. So lower motor neuron can be in the nerve, it can be in the muscle, it can be in the anterior horn cell, it can be in the myoneural junction, all these things. Myoneural junction very unusual because it will not start distally.
Yes.
So we want sensations were not affected, you said at the end. So
Yes.
it is very unlikely to be sciatic nerve, common peroneal nerve or S1 roots. So if it is a root or a nerve, it will be sensory motor. So
Yes,
sensory is not there.
Not
So if it was a flail one, then you are left with the motor nerves,
Yes.
motor roots and anterior horn cell.
Yes.
These are the three things in the element. Because you did not tell me whether it was flail or stiff, we will have to take it as either way, we do not know.
Okay.
So let us imagine it is flail. We have cut off the nerves, we have cut off the roots. You are left with the motor radiculopathies, or it may be motor nerves, or it can be anterior horn cell. Or muscle disease also out, myoneural junction also out among the purely motor syndrome, because myoneural junction disorders involve the proximal and the bulbar muscles. They do not start in the distal muscles. So you will not consider myoneural junction at all. You will not consider muscle disease because muscle diseases are symmetrical. They do not start asymmetrically, and primary muscle diseases do not become manifest in the 7th decade. They are manifest in the first 4 decades. They do not become symptomatic in the 7th decade. So myoneural junction and muscle disease are excluded for obvious reasons. So whether it is a motor nerve, so is it a motor nerve involving the motor part of the sciatic nerve or common peroneal nerve, then you know that these nerves cannot be involved separately as motor because all the fibers are in one bundle. So sciatic nerve, common peroneal nerve cannot manifest as purely motor. So it cannot be a motor neuropathy. Motor neuropathies are common in some situation where the sensory is less dominant and they are bilateral. This is motor neuropathy with multifocal conduction block, affects middle-aged males and starts in the upper limb. So motor neuropathies typically start in the upper limb. That is called motor neuropathy with multifocal conduction block, usually in the 4th decade. And distal lower limb involvement is very, very rare, and it is an exception rather than an example. So motor neuropathies affect upper limbs, young males, usually 4th to 5th decade. So that, and very unusual in sciatic nerve and common peroneal nerve. So it is less likely. No? Then we will go to motor roots. So cauda equina. So cauda equina roots, last class I told that you have got a dissociated relationship between the vertebra and the spinal roots at various levels, because you are having 8 segments in the cervical cord and your cord stops at L1 lower down. But you have up to coccygeal segments. Cord stops at L1, but you have sacral, coccygeal, all those segments are there. And the cervical cord, you have got 8 roots and 7 vertebra. For this reason, there is a dissociated relationship. That is more obvious in the cauda equina region, because cord stops at L1 and you have got so many vertebrae below that. So each root in the cauda equina region to reach its corresponding foramen remains longer distance free, whereas cervical up to 4 or 5 they immediately enter, then upper thoracic enter little higher, but when you come down, they travel long distance because cord has already stopped from that, like the cluster of the horse hair, all the roots are hanging, and depending on whichever is the root number, they travel varying distance before they join the intervertebral foramen. There, what is the second unique feature? In the other regions, the motor and the sensory roots join in the intervertebral foramen. Here, because they travel a longer distance, they stay separate throughout that distance. So in the carda icona region, you can have purely motor, you can have purely sensory. So radiculopathy you cannot rule out. So that we will keep it as a possibility because distal dorsiflexion means L5. So L5 is already in the carda icona region. Motor radiculopathy is possible because it travels a long distance from the L1 to enter the L5 foramen. And after entering that foramen only, it joins with the sensory root. So it is very much possible. It may be a asymmetrical. So we typically describe a carda icona as asymmetrical, areflexic with late bladder. Asymmetrical, areflexic with late bladder is typical carda icona. So it is asymmetrical. We don't know LMN or UMN. We have not got the history appropriately. And it is L5 apparently because it is a foot draw. And pure motor and pure sensory is possible in the carda icona region. So it is possible. So L5 root is possible. So we'll keep it there. The next will be dorsiflexor anterior horn cells. That is L5 anterior horn cell. I said that it is not possible in the nerve level anterior horn cell. So now how are you going to differentiate L5 motor root from L5 anterior horn cell? That is the question to you which you will have to answer. Sensory motor roots means you will say root pains are there. You have got sensory loss. So it's a root. So if it is a sensory motor root, sensations and presence of root pains will help you to understand that it is a root. But if it is only motor root, you cannot apply that point. So now tell me how to differentiate L5 motor root from L5 anterior horn cell. And the fan for that. How to differentiate L5 motor root from L5 anterior horn cell? Anyone wants to answer? Answer.
Anterior horn cell will be having fasciculations.
Okay. Fasciculations may be there.
Yes, ma'am. And the wasting will be prominent.
In L5 root, wasting will not be prominent.
Both.
You see, L5 root, what are all the muscles that are supplied by the L5 root?
Dorsiflexion.
Name the muscles. Name the muscles supplied by the L5 root.
Tibialis anterior.
Tibialis anterior is L4.
Okay.
So extensor hallucis longus. Extensor digitorum longus. Extensor digitorum brevis. Gluteus medius. Gluteus minimus. That is the L5 root supplied muscles.
Yes.
So L5 root supplies extensor hallucis longus, extensor digitorum longus, extensor digitorum brevis, gluteus medius, and gluteus minimus.
Yes.
You see? So these are the muscles. So that if there is a L5 radiculopathy, even though patient may be showing the symptom maximum in the extensor hallucis longus, that is the ultimo moriens. We say that extensor hallucis longus will show maximum symptoms. But when you examine, if you carefully look for, you will find that the person is having slight waddling on that side and hip abductors are slightly weak on that side compared to the normal side. That will say it's a clear radicular pattern. Nobody can imitate because one is proximal and one is distal. The muscles are separately supplied proximally and distally. So L5 radiculopathy, psychogenic foot drop, a patient cannot, so the abduction he will not know. So he will not imitate it. So L5 root means extensor hallucis longus gets maximum symptomatic. But extensor digitorum longus, extensor digitorum brevis, gluteus medius and minimus, so hip abduction will also be slightly affected. Whereas what is anterior horn cell pattern is, it is all groups of cells. You know, in the ventral horn in the spinal cord, there is a peculiar arrangement. You see, you know, the ventral horn has got medial fibers, central fibers, and lateral fibers. Lateral fibers go to the appendicular muscles, medial fibers go to the head and neck, and intermediate goes to the central structures. And in the limb, that is the outermost anterior horn cells are supplying the limb muscles. And cervical limb in the cervical cord, lumbar in the lumbar anterior horn cells to the leg muscles. There is something called motor unit. What is a motor unit? A single anterior horn cell with its axon and the muscle that it supplies is called motor unit. A single anterior horn cell with this axon supplying a muscle fiber is the motor unit. So in the ventral horn, it is not like a root. Root is already organized for a leg and it supplies a group of muscles. Whereas in the ventral horn, there is a motor unit. So that is called as a motor unit pattern. That means it is having units within the muscle. Even within the extensor hallucis longus, all the fibers will not be wasted. Even within the gluteus medius, all the fibers will not be wasted. So anterior horn cell pattern is motor unit pattern. So we call it as a selection within a territory. So let us imagine it is L5 radiculopathy and you are examining. You find that the EHL is slightly weak, EDB and EDL are normal, gluteus medius is slightly weak, gluteus minimus is normal. So that is, you think it's a root, but there are selected motor units. We call it as finger drop in the upper limb. When there is an anterior horn cell pattern, even though all the fingers are supplied by C7 root in the upper limb, only one finger will drop like that. So that is very, very unique. So it is selection within a radicular territory, which is otherwise called as motor unit pattern. So you first decide, okay, my patient has got a flaccid foot drop with no sensory involvement. So it may be motor root in the cardia equina or it may be a anterior horn cells. And start examining EHL, EDB, EDL, and you are surprised that only EHL is slightly weak, or the second toe is slightly weak, other toes are all right, or other toes are weak and EHL is all right, and hip abductors are all right. That is called motor unit pattern. Okay. So to differentiate between anterior horn cell and motor root, the most important thing will be the pattern. Motor roots will supply all the muscles that are supplied by that root, whereas anterior horn cell is a motor unit pattern. So it will select some fibers within a muscle or within a motor territory. That is one. Second, fasciculations, of course I agree. But in the distal muscles, in the small muscles of the foot, is very difficult to, you don't generally find. You find it in the bulky muscles, pectoralis, deltoid, infraspinatus, facial muscles, tongue muscles. You see them, but very, very uncommon. I have not seen fasciculations or fibrillation in the muscles of the leg so far. It's very difficult to see clinically. Electrophysiologically, you will be able to pick up, but clinically, it is very difficult. So fasciculation will not get. Second point, you will not be able to demonstrate. Then third point will be, because it is only some motor units, reflexes are not altered, even if that root perceives a reflex. Whereas L5 S1 root hip extensor will go, plantar flexion is going, angle jerk will be lost. In that territory, also patient will have normal reflex because it is only motor units, single units are destroyed in the early stage. The reflexes are not suppressed. So first point is a motor unit pattern. Second point is reflexes remain retained till very late. And in certain distributions, you may be able to demonstrate fasciculations, not everywhere. You may show some tremors, especially in the upper limb. The lower limbs, the tremor has to be demonstrated by making the patient lie down and the foot hanging. And you may see tremors. That's an indirect evidence of fasciculation. So tremors, slight trembling may be seen. Yes, so you understood what is anterior horn cell pattern and an anterior root pattern.
Yes, ma'am.
Anterior root means all the muscles supplied by that root will be affected. Anterior hornsel pattern means some of the muscles will be normal, some of the muscles will be affected, and even inside that affected muscle, some groups will be severely affected and the rest will be normal.
Yes, ma'am.
That is the reason you get toe drop, finger drop in anterior hornsel disease. So now when you examine, your differential diagnosis is going to be between anterior root and anterior hornsel. So you will specifically look for this motor unit pattern.
Yes, ma'am.
Then is there any dystonia? You did not tell that the limb is going on twisting. If it is dystonia, continuous twisting is very typical. So usually when the patient starts walking, it will be action induced aggravation. When he starts walking, there will be some twisting, and when he starts progresses with walking, the limb will twist very badly and it is stiff and remains like that. He has to stand, relax, touch the floor, that it will go. So dynamic change in the foot drop with continuous twisting, which increases with the task. If it is there, it will indicate a foot dystonia. So you will go to the basal ganglia. Then if it is a stiff foot drop without continuous twisting, you may think of a corticospinal tract. So these are the possibilities we will keep for a purely motor foot drop. So tripping indicates you had a foot drop. Whether it is LMN, UMN, you could have determined if the history was available. Because it is not there, we are left with whether it is a motor root, is it a anterior hornsel or motor unit pattern, or is it a dystonia, obviously not there, or is it an UMN pattern? We don't know. We will keep it like that.
Yes,
The next you said that he had difficulty in climbing, getting up from sitting posture. No?
Waiting position. Yes, ma'am.
What was the difficulty, ma'am? I have
Was not
discussed
able to-
before also. You have to tell them what is the semiology. So first you say, my patient had difficulty in getting up from sitting posture. All of us have. You may have knee pain, you may have hip pain, you may have back pain. So he is not troubled by, he is a 72-year-old person. He can have osteoarthritis, no?
Yes.
So you should tell that.
Painless.
So I have told it before. In subsequent classes, you should apply that.
Okay.
So history taking improves. Neurology is 99.9% clinical and 0.1% laboratory. No? So that is why you subsequent classes, you should not sit in the square number 1. You should apply that and improve the history. No?
Yes.
So you should say, my patient is unable to get up from the sitting posture, but it is not due to pain. He has to, his leg feels stiff, so he needs somebody to lift him up. So if the patient says that I do not sit at all, and if I are forced to sit in the floor, my leg feels stiff and somebody has to lift me up, then it is an upper motor neuron. Upper motor neuron patient cannot flex his legs and bring it under the thighs and support his trunk with the hands and get up. It is not possible.
Yes.
So it is painless, so it's not osteoarthritis.
Yes.
He needs help, then it is spastic. So if the patient says, I am able to flex my leg, even though I am tripping, I am having some distal weakness, but I am able to flex my leg and bring it under the thighs. But when I try to get up, I have to plant my hands on the floor and support myself to get up. That means if you have a hip extensor weakness. So as I have told in the previous sessions, getting up from the sitting posture is by spine extensor, hip extensor, knee extensor, and dorsiflexor at the angle. They are the agonists. Spine extensor, hip extensor, knee extensor, and dorsiflexor at the angle are the agonists. Any one of them can be affected. He already have dorsiflexor at the angle affected. So how will it manifest? When I am trying to get up from the floor, I have to fix my angle. Otherwise my angle wobbles and twists. I sprain my angle. When I get up, I always sprain my angle. Already he has got dorsiflexor, which is an agonist in getting up, is affected. So if that is the culprit, patient will be able to tell. You should ask.
Yes.
He is a teacher, he will certainly be able to tell. So patient will tell, my angle is unstable, I twist my angle. So I sometimes hold my angle with my hand to prevent it wobbling, then I am all right. That means it is the dorsiflexor of the angle which is already affected. That is the cause for the getting up from the sitting posture difficulty. Instead, if the patient says, no, I am able to get up, but when I try to stand, I am buckling and falling. That means knee extensor. So getting up is dorsiflexor of the ankle, knee extensor, hip extensor, and spine extensor. So if he says, when I get up, I am buckling and falling, then you know, okay, my patient is already having dorsiflexor of the ankle weakness. Now he is developing quadriceps weakness. So that is the second thing. That is why you should elicit this. Now we have now gone some way into our sessions now. You should apply it in subsequent classes. So useful. You will feel excited that you have an MRI which is superior to the 1.5 or 3 Tesla MRI outside available. You can prove it yourself any number of times. So next, okay, these parts are all right. I'm not buckling. But when I try to get up, I feel that I have to bend my trunk to elevate my hip. That means it is the hip extensor weakness. If the hip extensor is weak, he will not buckle, he will not wobble at the angle. Instead, when he tries to get up, he will bend his trunk forward. Why he is bending his trunk forward? Because the hip extensor is weak. He is using the spine extensor to pull the hip up. You know that erector spinae is having an origin from the iliac crest. So it can lift the hip. Erector spinae origin from the iliac crest can help the hip to be lifted. So it is using that. You have been told to walk, sir. So whatever possibilities there, use to lift your hip. So the brain will bring out that erector spinae is there. It is having origin to the iliac crest. So let me use that. So why you are bending? You see, now I am here. I cannot be in my hospital now. You see. Similarly, now I am here. I cannot be with my mother now. So like that, when the erector spinae has to erect the hip, it cannot erect the spine. Because it cannot do both work together. So erection of the spine done by the erector spinae is switched off. And all the force in the erector spinae is directed towards the iliac crest to lift the hip.
Okay.
So patient becomes bent. Understood? Is it clear? Is there any doubt you ask me? Next class you should apply all this, and I should not be discussing anything. The diagnosis will be obvious. You will sit on the diagnosis. No? That is what I tell. You will know the structures involved very clearly. So then slowly what will the patient do? The erector spinae will lift the hip. Then now you have to erect the spine. Then only you can walk. So you will lock your leg with the cruciate ligaments. You have got semilunar cartilages, anterior cruciate ligament and posterior cruciate ligament. Using these things, you will lock your knee. By locking the knee, patients can't stand, they cannot walk. So the body will use that apparatus and slowly lift the trunk, and what it will do, one hand is kept on the floor and one hand is put on the knee. That is called tripod sign. So first patient was bent, standing with the both hands down. Now he is trying to stabilize his weak leg using the one hand, putting it on the knee with to stabilize the cruciate ligament, and the opposite hand is in the floor. That is called a tripod sign. Then the tripod is stable, so person will know I can move up. So he will put that hand also on the opposite knee. That is called a Gower sign. So Gower sign indicates gluteus maximus is weak. So he will then slowly erect the spine. Now the erector spinae is not erecting the hip. The hip is fixed in a standing posture by the ligaments, and the erector spinae is erecting the spine.
Yes.
So if the person says like that, then you know that he is getting up from sitting posture is due to gluteus maximus. And if it is due to trunk muscle involvement, patient cannot erect himself. It is like the upper motor neuron. Somebody will have to pull him, and when he is pulled up also, he will stand bending only.
Yes.
So that is obviously not there. So erector spinae is not the culprit. It could be dorsiflexor of the angle if you have elicited the history and patient said my angle was twisting and wobbling. That was the difficulty.
Yes.
Otherwise, buckling. He was not buckling, no?
No.
He was not buckling, I suppose.
Initially,
Was he buckling at the knee?
Initially
If
he
he was
didn't have
buckling it,
no, ma'am.
he didn't have.
No.
So whatever was the history, that will help. It's not erector spinae because he was not bent. So it could be any one of these muscles or all of them together. That depends on what were the functional disability that patient had while getting up from the sitting posture.
Okay.
If you had elicited that, we will know the demarcation.
Okay.
Then you said that he had climbing. That also I had discussed before. So climbing, your hip flexors will help you to put one leg on the step above. So if the hip flexor is weak, patient will tell, I am not able to do alternate climbing. Instead, I have to lift my one leg with one hand, put it on the step above, and then the next leg is flexed and kept. So if it is iliopsoas or the hip flexor weakness, patient will tell, I cannot do alternate climbing, and when I am climbing, to put one leg on the step above, I have to lift my leg and put it on the step above. So you should elicit that history. You should not stop by translating what the patient is telling. You should elaborate.
Yes.
Yes, you know the anatomy, patient doesn't know. No.
Yes.
So he say, okay, my patient cilia, so yes, madam, you can tell that. If he is telling, no, I can put my leg above, I can lift my foot, leg and put it on the step above, no problem. But once I am trying to bear my weight on that leg, that hip slightly comes down. So I feel that I am going to fall, but I manage by holding on to the side rail. If he says that, it is the waddling muscles, gluteus medius and minimus. I am able to put my leg above, but when I put my weight on the right leg and try to elevate my left leg, my hip is sort of waddling and I feel I may fall backwards or sideways, so I hold on to the side rail. That's clearly gluteus medius and minimus. And if he says that I am not dropping my hip, I am not using my hand to lift my leg and put it on the step above, but when I try to move up, I have to slightly bend. That is again the hip extensor.
Okay.
So when the climbing, you have iliopsoas first, then you stabilize using the gluteus medius and minimus, then lift your pelvis using the gluteus maximus, and then ascend through the erector spinae. So all that can be elicited, or more than one level of involvement is there that will clearly tell you what is the cause for his climbing up. Yes. So climbing up is more difficult than climbing down, means LMN disease. But if climbing up and climbing down are equally difficult, it is UMN disease. Because in UMN disease, it is a stiff limb. Now we are differentiating between the UMN and LMN motor. So if it is UMN motor, patient will say, because it is a kinetic melody. In upper motor neuron, it is the no muscle paralysis. So this muscle pattern which we discussed will not be there. It is a movement pattern. We call it as kinetic melody. It is the melody of the movement that gets affected in upper motor neuron. So everything will be difficult. Climbing up is also difficult. Climbing down is also difficult. My leg is stiff. If he is saying that, it is upper motor neuron. Whereas lower motor neuron, muscle by muscle, just like I analyzed now, next class you should elaborate your history like that. Okay, ma'am?
Okay, ma'am.
If the person says climbing up was all right, but down is difficult, down is more difficult. We call it as lumbar canal stenosis. We are even thinking of motor radiculopathy in the cardiac vena. So that will be a very useful point. My patient is, we are suspecting whether it's motor root or anterior console. That is where we left with the first symptom of tripping. No. Yes, so if the person is saying, madam, even though I am tripping, otherwise I can climb up little better. But when I am climbing down, I become very weak. That means it is root, lumbar canal stenosis, where the nerve roots are jammed. Because when you climb down, we naturally bend our trunk. Then the roots become stretched. So climbing down is more difficult, means it is favoring a
stenosis.
Yes. So we are keeping 2 DDs. So as we improve with each symptom analysis, we should be improving in our localization, provided the history has been properly taken. Understand, ma?
Okay,
so if you have asked, are you waddling? Are you lifting your leg with your hand? Are you able to do alternate walking? What is the problem? It's up, down, everything is difficult. All those histories, if you have elaborated, we will clearly know Yemen or LMN. So next class, anybody presenting, if similar case, you should analyze the symptoms which we have already discussed should be incorporated into subsequent cases so that we will go upper and upper in the neuraxis slowly. Understood, ma? No?
Yes, ma'am. Yes,
So
ma'am.
now we do not know what is his problem in climbing up. So climbing up is difficult. Okay. So what the patient tells should be elaborated with your knowledge.
Yes.
So we become wiser at the end of our history only. So now we'll say, okay, it's difficult because semiology is not there. We'll keep it like that. It could be any of these things. The next you told that this rapidly deteriorated and patient developed the right leg incidence gradually was he was not able to grip slippers while in
It was
spite
also
of.
similar to left shoulder, ma'am.
Okay. So slipping of the thing with knowledge is indicating what muscle, ma?
Sensation was intact, ma'am.
Yes. Which muscle then?
Yes, ma'am.
Indrashi. Indrashi. Which
Yeah.
muscle will make slippage of supple with knowledge? Indrashi.
Yes.
So initially it is a dorsiflexor which made the patient trip. Now we have got indrashi involvement.
Yes.
Here would you like to tell me how to differentiate EMN? With knowledge, EMN can also slip, no? So hemiplegic patient supple will slip, no?
Yes,
It is
ma'am.
EMN.
Yes.
What will be the symptom? Patient will have difficulty in putting his feet into the chapel. Because you just remember upper motor neuron, movement paralysis. Lower motor neuron, muscle paralysis. In upper motor neuron, why is there movement paralysis? Movement has got a pattern.
Yes.
Supposing I want to speak something. So to bring out the correct sound, what all muscles in the vocal cord, what all muscles in my lung, what all muscles in my lip should be put into action so that the correct word is pronounced. That is the motor schema. So
Yes.
that motor schema fails. As I have told, motor schema has agonist, antagonist, synergist, fixator in the lower motor system. They are properly coordinated. So in upper motor neuron, movement paralysis due to failure of formation of the proper motor schema. There is no muscle paralysis. Whereas
Yes.
in LMN, it is muscle. So if I say interosseous, it is a muscle. No? So if the interosseous is weak, only the interosseous mediated activity will be paralyzed. So interosseous is for adducting. So patient will not be able to hold the chapel and walk. But he can put his feet into the chapel because interosseous is giving space. It can be easily incorporated. You can remove the feet out of the chapel easily. That is also possible. You cannot hold on and walk. Whereas in upper motor neuron, what happens? It's a
Not
motor
able to-
schema.
Yes.
Everything needs the schema. So he cannot put his feet into the chapel properly. The toes, somewhere the toes will be antagonist activated. Somewhere it will be agonist activated. So one toe will be medial, one toe will be lateral. So patient will tell, I will have to use my hands, separate my toes and put my feet into the chapel. So putting on the chapel is weak. Holding on and walking is weak. And removing is also weak. All three things are weak means it is upper motor neuron. It is not muscle. It is the motor schema. Motor schema to carry out the movement that has been formulated wrongly because of the upper motor neuron problem. So all faculties are affected means upper motor neuron.
Yes, ma'am.
It's only holding on and walking means lower motor neuron.
Yes.
So if you think it is lower motor neuron, it is interosseous. And if it is tripping due to lower motor neuron, it is EHL and EDL. Then climbing up weak without the patient lifting his leg and putting on the step above means it may be hip abductor or hip extensor. Because it's not bent, we are not thinking of spine extensor.
Okay.
Probably. If
Yes.
it is stiff limb, it may be Yemen also, that is not there. So slipping is also finished, then unable to get a walk. Next month. So next was 5 months, he has found that his upper limb, he has become bedbound.
Yes, ma'am.
He has become bedbound because both legs have been affected. Is it
Yes,
so?
ma'am. Yes, ma'am.
Okay.
He had a
If what,
difficulty in rolling over,
yes,
roll over in the bed, ma'am.
yes. What are the muscles which are helping you to roll over, ma?
Abdominal muscles.
So rolling over means
Yes.
turning from left side to,
Right.
if you are lying on the left side, you want to twist your trunk towards the left side. If you are lying on the right side, you want to shift your trunk towards the right side. So what are the primary muscles involved? It is the obliques. No?
Yes, ma'am.
You have got external oblique and internal oblique muscles.
Yes.
So the right external oblique and right internal oblique help you to tilt your trunk towards the left side.
Left side.
So right-sided obliques will help you to tilt your trunk towards the left side.
Yes.
If the left-sided obliques will help you to tilt your trunk towards the right side.
Right side.
So if he is not able to tilt to the left side, not able to tilt to the right side, it indicates that the oblique muscles on both sides are affected.
Affected. Okay.
Oblique muscles on both sides. No? So
Yes,
that means the oblique muscle. Was he stiff while turning? No.
Yes, ma'am.
Was he stiff?
No, ma'am.
No. Was he feeling stiff while turning? The
No, ma'am.
patient says that my body is stiff like a log of wood. Then it is upper motor neuron.
No,
He was not feeling stiff, no?
No, ma'am. No, ma'am.
In that case, it is okay. It is oblique muscles on both sides.
Okay.
Oblique muscles on both sides are affected. Now the upper limb, you told that mixing of the food. So mixing of the food is like this.
Yes.
So mixing of the food is mainly a action of the lumbricals. Mixing of the food is lumbrical. So mixing is difficult and buttoning is normal. Means buttoning is done by the opponent's muscle. Now buttoning is affected. I am just teaching you the anatomy. No.
Yes.
You said mixing is weak.
Yes.
Mixing is weak means it may be lumbrical if it is in the lower motor neuron. Even upper motor neuron patient cannot mix. But it will be not just mixing. He will not be able to hold a pen. He will not be able to do extension. All movements are affected means upper motor neuron. Only mixing of the food means it may be lumbrical. So he has mixing difficulty. If it is in the element, it is lumbrical. He has buttoning difficulty. It is the opponents. This opponent policies and the finger extensors. They are helping in buttoning. Buttoning is helped by opponent group of small muscles and flexor group of long muscles. Then he is not able to hold the glass of water. That's a long flexor. Long flexor. So if it is element in the upper limb, it is lumbricals, it is opponents and the long flexors because of unable to mix the food, unable to button and unable to hold a glass of water. But if it is upper motor neuron, everything will be affected, but the worst affected will be the finest movement.
Yes.
Holding pen and mixing food will be worst affected, whereas holding a cup will be much better. Because kinetic melody is most important for the finest movement. A hemiplegic patient might have recovered completely from his paralysis. He have thrombolized in time and everything happened perfectly. But patient is a computer engineer or somebody like that. He says, okay, I have recovered, but now I am trying to type on the keyboard. I am unable to do. That will be a surprise for him because that's the finest movement. So finest movement, piano playing movement, playing on the veena, typing the typewriter or computer. Those finest movement becomes worst affected. They need more coordination. They are small motor units, more coordination. So if the patient says the finest movement is very, very difficult, I cannot mix my food at all, but somehow I can manage and hold the glass of water, then you know it's a kinetic melody, finest. If it is in the lower motor neuron, muscle pattern, lumbricals for mixing and holding the cup of water is long flexor, opponents for buttoning, in your case, all are affected. So if it is lower motor, all muscles are affected. If the involvement is uniform, it is favoring an element. If the patient says the fine movement was worst affected, probably UMN, because we need more data like stiffness and all those things have to be obtained. Then you said that later he developed abduction of the elevating the hand above the head.
Yes, ma'am.
And was affected.
Proximal
Elevate which one? Which is the muscle used for elevating the hand above the head?
Deltoid, ma'am.
Yes, deltoid.
Supraspinatus, deltoid.
And trapezius.
Yes, ma'am.
You see,
Trapezius.
first 30 degrees is supraspinatus. Then 30 degree to 90 degree is deltoid. Above 90 degree is trapezius. So all three faces are they affected?
No, ma'am. He was able to lift, ma'am, up like above head. He was not able to lift, ma'am.
That means probably supraspinatus is not that much affected. Probably it is the deltoid and the plus minus trapezius. So approximately first part is able to lift. So distally the small muscles, forearm muscles, and proximally probably deltoid plus minus trapezius.
Yes.
Then what else you said that he is unable to speak? He told me that he has some problem in speaking. No.
Yes.
Next thing is speaking or teaching?
No, speaking, ma'am. Difficult in speech.
So you told that speaking is effortful.
Yes, ma'am. He used to strain, ma'am, while speaking.
And he could comprehend very well.
Yes,
he can read, he can understand what is spoken to him. Yes, but only one component is affected, that is production of sound. So it is a speech disorder or a language disorder? What disorder, ma'am? How do you differentiate speech from language? Would you like to tell? You are hearing, huh?
Yeah, now I can hear.
Speech means, you see, language, we say that language is ability to convert thoughts into comprehensible modes of communication.
Yes, ma'am.
So language means thought is there and you want to convert it into various modes of communication. That involves writing, speaking, listening to spoken words, and reading and repeating. Yes. So if it is language, all components will be affected. So converting thoughts into comprehensible modes of communication. Yes. That is language. Yes. Whereas speech is converting language into audible sounds. Yes. Only one sound. So you said that your patient is able to comprehend. Yes. He is probably able to read. He is probably able to not able to write, maybe because he is already having an element problem, but only sound production is altered.
Yes, ma'am.
So it is not language, it is speech. Speech. Only sound production is affected. So it is not a language problem, it is a speech problem. No.
Yes, ma'am.
So that is called as dysarthria.
Dysarthria.
So this is not a dysphasia, this is a dysarthria. What are all the types of dysarthria you know of?
Bulbar dysarthria, pseudobulbar dysarthria, cerebellar dysarthria.
So dysarthria is classified into flaccid, spastic, ataxic, dyskinetic, and cortical.
Yes.
Flaccid, spastic, ataxic, dyskinetic, and cortical. Flaccid is LMN. Flaccid can be due to tongue, lips, and palatal muscles. If it is tongue is important for producing sounds which need L. So lily, lalla, no? Those kind of letters are coming, those words are very difficult. So that is a flaccid speech. So flaccid speech is characterized by dysarthria for specific letters. So labials means PB, dentals, edentulous person, DT, gutturals, palate, NG, GG. So if the person is telling that I am having difficulty in speaking out, all other compounds are all right, and this is worst when I am mentioning papadam or papa or something like that, then you know something has happened to his orbicularis ovaries. So it's a labial type of flaccid dysarthria. If the L is affected or D is affected, it is lingual. Dot, log, lily, no? Yes, then you know maybe my patient's tongue is affected. And if he says that when I am telling bring, sing, everybody is telling I am speaking through my nose. Then you know it is the gutturals. So flaccid dysarthria can be due to labials, it could be due to linguals, or it could be due to gutturals. So all this will produce specific defects. So that is flaccid dysarthria. Yes. Only specific defects means it is flaccid. Whereas spastic dysarthria, patient will not have this kind of specific letter-based defect. But again, the kinetic melody is affected. So he will strain and squeeze out his words because the whole body is stiff. So it will appear that he is squeezing out his words. When we squeeze out, what happens? The syllables will run into one another. When you are squeezing, you cannot split anything. It runs into one another. Just like squeezing your the dosam on this, what is that, idiyappam and all, when you make, you squeeze the maavu, no? It comes in a continuum. The maavu which has been put inside that idiyappam kulal will come in a continuum. Yes. So the letters come in a continuum. That is called, the syllables are not separated. So it will be effortful speech and syllables run into one another. Okay. So it is mixing of syllables in a continuous way without breaking it. Yes. That is spastic. So yes. You said that it is effortful. So whether there is a element of spasticity in his speech, that's what I thought from the way you said. Yes. So that is spastic. Then you come to ataxic. Ataxics could be scanning, or it could be scanning speech when it is split into syllables. When you say Chakravarti Rajagopal Achari, no? Yes. You say that Chakravati. So that is a typical scanning speech of cerebellar disease. Cerebellar speech can also produce an explosive speech. So what is there? So if you say Chakravarti Rajagopal Achari, so Chakravarti Rajagopal, so some point suddenly you make an explosion where it is really not needed. So these are the staccato speech and the scanning speech. The staccato speech is where you have got an explosive character coming in between where it is really not warranted. That is staccato speech. So ataxic may be scanning or staccato. Staccato when there is an explosive component, scanning when the syllables are split into the subcomponents. Then you go to the dyskinetic. Dyskinetic may be hypokinetic or hyperkinetic. Hypokinetic is Parkinson's disease. So like the bradykinesia in movement, hypokinetic speech, patient will start his talk very loud. As he keeps on speaking, the voice volume will progressively go down. It is like micrographia. Yes. Progressive smallness of letters. Progressive decrease in the voice volume. So that is Parkinsonian speech. Hypokinetic speech. When he speaks, he starts, it is little louder, and as speech progresses, it becomes lower and lower voice volume. That is hypokinetic. Hyperkinetic is chorea of the tongue tremor, tongue dystonia. So here what happens? Tongue tremor. So when he is speaking, the words which contains the L or so, it will become shaky. The letters words which need the linguals become shaky. Yes. That is tongue tremor. Yes. Voice tremor is different from tongue tremor. Voice tremor is seen in old people. They have a shaky voice. Whereas tongue tremor is, it is the linguals which shake. That is tongue tremor. Tongue chorea. Chorea, when like any other choreic movement, rheumatic chorea can manifest in the tongue. When the choreic movement comes, suddenly the patient will stop the speech. And when that chorea has disappeared, he will start. So sudden unwarranted stops during communication is very typical of choreic speech. Sudden unwarranted stops. Choreic speech. Yes. Then what about dystonia? When the patient says, when I am speaking, suddenly my tongue twists and I am forced to stop. That is dystonia. That is hyperkinetic. Under hyperkinetic speeches, you have got tongue tremor, you have got chorea, you have got dystonia. No? Yes. So then there is something called cortical dysarthria. Cortical dysarthria is very peculiar. It is like a childish speech. All the words are there, grammar is there, everything is there. But you know, you might have seen mentally subnormal children, even when they grow up into adults, they will speak like children. So it is due to some disorganization in the motor input into the Broca's area, commonly seen as an inherited condition in, it's a childhood developmental condition where people are MR and their speech does not mature into the adult type of word handling. Instead, it has got a childish. Sometimes in an acquired lesion to the Broca, which keeps the Broca's area intact, but connections to the Broca's area are partly affected. They get that childish type of speech in later age group as an acquired condition. That is called cortical dysarthria. It's an exclusion diagnosis. Sometimes you get Pierre Broca's also has got a dysarthric element, but that is an aphasia, not a dysarthria. No? Yes. So you understood? Yes. So your patient's speech appears to be probably spastic because you said it is effortful. So now if you consider the whole thing is purely motor, agreed, asymmetrical to start with, and it picked up distal muscles first, and probably it picked up the EHL, dorsiflexors of the angle. Then what other muscles are involved in between, we do not know, but probably picked up the hip extensors and the spine extensors, the obliques, then the upper limb, distal muscles, and the proximal muscles. And now the person has got probably some upper motor neuron involvement evidenced by the spastic speech. Yes. Then you said that he has, so this is a structures involved. In short, these are the structures involved if it is in the lower motor neuron. We do not have any evidence from the history which you have provided to say that there is upper motor neuron except the spastic, probably spastic speech. I have to hear that speech, then I will be able to clarify it for you. But if the speech is spastic, it is some upper motor neuron element is there. Yes. Then you said that he is having some twitching movement. Where did you see? Patient said or you said? You asked what all areas, ma'am?
Patient's wife noticed, ma'am, over the arms. Yes, ma'am, over the arms, thighs, and when later phase, they also noticed over the tongue.
So it is diffuse.
Yes,
both upper limb, lower limb, and tongue.
Yes, ma'am.
Did the patient say or the wife only found out?
Wife found, ma'am.
So it is objective, not subjective. So widespread fasciculations, which are objective, not subjective, in muscles which are already weak, that is pathological. You see?
Yes.
So you can have physiological fasciculations. Pathological fasciculations are objective, they are seen in weak muscles, and they are widespread.
Yes.
Whereas physiological fasciculations happen when you are tired or when you are under stress, and especially we call third year syndrome, when we suddenly go into third year and see a very severely damaged patient, gets frightened and start twitching. No? So this will be subjective twitching. Objectively to demonstrate, it is very difficult. Patient will tell, when I am in my room and I am studying medicine, I am getting twitching over my deltoid. No? Okay, you show me. Patient will say, now it is not there. So that is more subjective. So subjective twitching and very rarely objective. Yes. That is one point for physiological or psychological. Second, the muscle is having normal bulk, normal power. And third, it is usually in one site, not widespread. So subjective, localized, and normal muscle. That is more physiological or psychological. Electrophysiologically also their unique characters are there that we will not go into now. That you will study when you become DM neurology. Okay. So now there is a widespread movement which is objective, seen in wasted weak muscles, and it is widespread. So it could be anything like fibrillation, fasciculations, myokymia, cramps, contractures, so many things. So last class I discussed something about cramps and contractures, I think, or the class before, I don't know. So now you said it is a fasciculation. Why did you think it's a fasciculation, ma'am? In other words, you can get fibrillation, you can have fasciculations, you can have myokymia, which are painless movements,
Yes.
whereas cramps and contractures are painful movement. So this is painless.
Yes.
So it could be fibrillation, it could be fasciculation, or it could be myokymia. How do you differentiate?
Fasciculations can be seen with naked eye, whereas fibrillation difficult, or it's not able to see.
Agreed. So fibrillations are not visible to the human eye except in the tongue, whereas fasciculations are visible. So in this patient, it is not in the tongue. In the tongue also it was there, but it is in the whole body. So when the whole body it is visible, it is less likely to be fibrillation. So you thought it is fasciculation.
Yes.
What else more? How to differentiate from myokymia? Myokymia will happen in motor radiculopathies, motor neuropathies. So motor radiculopathies and neuropathies, it will produce myokymia. Yes. So how do you differentiate fasciculation from myokymia?
Myokymia, they are also involuntary muscular movements, ma'am.
Yes.
It can be visual.
That's why it becomes a differential diagnosis for this case.
Yeah. Like as a vermicular or continuous rippling movements are seen.
So it will be a shifting movement. Vermiform movement, you said correctly. So it will shift from one group of muscle to another group of muscle. And it is not elicited by tapping the muscle. Thereby it indicates it is not due to myotatic irritability. Fasciculations, there is increase. So it will not shift. It involves one motor unit. So it will be in that place only. So fasciculations are not showing the vermiform shifting movement. They are in that place only. And they can be aggravated by hyperventilation, and they can be aggravated by tapping the muscles. By hyperventilation, what happens? There is alkalosis, ionic calcium comes down, irritability of the muscle becomes more, so it becomes visible. By tapping also, you are producing the phenomena called myotatic irritability. Yes. Whereas myokymia is haptic conduction between different motor groups, muscle groups. So by contiguity of the muscle membrane, they become activated. So it's a vermiform movement. It does not become aggravated by hyperventilation. It does not become aggravated by tapping. Yes. So that is how we differentiate. So vermiform movement was not there, and you could not aggravate it by tapping. You could not aggravate it by making the patient hyperventilate. So probably it is fasciculation. Yes. So theory sake, I told that myokymia is haptic conduction from adjoining muscle groups. Adjoining muscle groups following acute denervation, not chronic. Whereas fasciculations and fibrillation are chronic denervation. Yes. Myokymia is acute denervation. Following acute denervation, neighborhood muscle fibers become haptically activated, resulting in a vermiform movement. That is myokymia. So Guillain-Barré syndrome, acute radiculopathies of any cause, no? Yes. You get that. Whereas fasciculation and fibrillations are chronic. So what is the mechanism in fibrillation, ma? Pathogenesis of fibrillation.
There are
fibrillations are
there are visible fine, ma'am, fast movements, because of contractions of motor unit, ma'am.
Fibrillation is contraction of not motor unit. Fibrillation muscle is spontaneous contraction of a single muscle fiber. Yes, single muscle fiber, not motor unit. Yes. Due to denervation, hypersensitivity to the chemical environment. You know that muscle fiber is like this, and the end plate is coming and joining that. So if the single muscle fiber is disconnected from that end plate, the acetylcholine released will not be in the myoneural junction. The acetylcholine released from that terminal axon will be smeared over the muscle fiber. So it's a single muscle fiber which suffers denervation supersensitivity to the chemical environment, that is acetylcholine. So a single muscle fiber which is disconnected from the terminal axon will twitch because of the acetylcholine that is smeared over that. That is fibrillation.
Yes.
It's not motor unit, it is a
Yes.
muscle fiber. Whereas fasciculation is due to motor unit, spontaneous contraction of a single motor unit due to epileptic conduction in the terminal axon. Fibrillation is in the muscle fiber membrane where the acetylcholine is smeared. Whereas terminal axon is there, a group of muscle fibers are there. The terminal axon is connected by a group of muscle fibers. But this terminal axon is unable to go retrograde to the cell body. So whenever an activity is starting in the muscle fiber, it goes, ascends through the axon. Suddenly it finds its pathway is blocked. It cannot go up. So it comes back and puts into action the same motor unit. So fasciculation is due to epileptic conduction in the terminal axon, putting into spontaneous activity a group of muscle fibers.
Yes.
Whereas fibrillation is
Individual muscle.
denervation sensitivity to the chemical environment of a single muscle fiber. And myokymia is acute denervation producing contiguous muscle fiber activation by contiguity. It is contiguity, nearness of the muscle fibers that makes it contract. That is myokymia.
Yes.
So you are correct. It may be fibrillation in the tongue. It may be fasciculation in the limbs. So purely motor, patchy, predominantly LMN plus some UMN and fasciculations. So your closest possibility you only know.
Yes.
So what is the possibility?
It could be like both the UMN and LMN.
Yes. So it may be both upper motor neuron and lower motor neuron. So if you are still thinking of muscle, myoneural junction, no?
Yes.
So
No.
purely motor,
Yes.
purely motor will be muscle, myoneural junction, motor roots, no?
Yes.
Or upper motor neuron, all are possible. So if you think it is purely motor muscle, then you cannot explain the upper motor neuron involvement. If you are thinking neuromuscular junction, again you will not get upper motor neuron involvement. No? So because of the involvement of the upper motor neuron, many things become deleted.
Yes.
You see, motor roots become deleted, muscle become deleted, myoneural junction become deleted. So when there is combination of upper motor and lower motor, there are only few differential diagnoses. No?
Okay.
That we will keep it there. And here I will tell that even otherwise, I have told myoneural junction not consider. I am just telling pure motor syndromes. If that is the situation, here we will not consider myoneural junction because started distally. Distally, asymmetrically. Whereas proximal asymmetrical may be myoneural junction, limb girdle type of myasthenia. Whereas distal is not at all myoneural junction. Motor radiculopathy is a possibility we considered, but that will not produce upper motor neuron.
Yes.
Muscle diseases, distal myopathies are there, but they do not start at this age group. At this age group, the muscle disease which manifests is polymyositis, paraneoplastic polymyositis. If you have a malignancy somewhere and polymyositis has a paraneoplastic manifestation, that involves the bulkiest muscles, neck muscles, esophageal muscles. So it is not likely to be polymyositis, it's not painful. So late onset muscle diseases are paraneoplastic, polymyositis, or metabolic myopathies like hypocalcemic, osteoporosis, osteomalacia, related metabolic myopathies, diabetic neuromyopathies. No? So those are the things. They all involve the proximal muscles. So in this age group, muscle disease, myoneural junction, even if there is, if the human involvement is not there, not at all possible. Muscle diseases of this age group, not at all possible because it started distally. No?
Yes.
And with the involvement of UMN, you are thinking that differential diagnosis becomes very less.
Yes.
So bulbar muscles and all four limbs and trunk muscles are involved. There is UMN and LMN. So the differential diagnosis in this age group for bulbar and limb weakness, if you have not examined the patient, it can be a craniovertebral junction disease, where you can have lower cranial nerve palsy, which produces the bulbar symptoms. Lower craniovertebral junction anomaly, high cervical cord compression, lower cranial nerves will be paralyzed. So you'll have bulbar symptoms and you'll have weakness of limbs, which are mainly upper motor neuron. So craniovertebral junction problems will produce upper motor neuron type of weakness of the limbs and bulbar muscles.
Yes.
Second, you can have multi-infarct. This person has got hypertension. You can have multiple infarct that can produce pseudobulbar palsy.
Okay. Yes, ma'am.
Vascular pseudobulbar palsy. There also the weakness is mostly it is motor. It can produce bulbar symptoms. It can produce limb symptoms. But the pseudobulbar of vascular, you'll have to differentiate from degenerative. That I'll come to later. So second possibility in this age group, considering his comorbidity, imagining that the limb is upper motor neuron, will be vascular pseudobulbar palsy. Third, you can have medial medullary syndromes. That's a medial medullary artery infarction that will involve bilateral pyramidal weakness and bulbar muscles. So medial medullary artery, when it is infarcted, patient will present with weakness of all four limbs and he will have lower cranial nerve palsy. Posterior column will be elicited on examination and the weakness will be upper motor neuron in the limbs.
Yes.
So now let us imagine our patient's limb weakness is not upper motor neuron, because you did not give us the symptom of spasticity or stiffness or heaviness or anything.
Yes.
So let us imagine my patient's limbs are involved in the lower motor neuron fashion. So if it is involved in the lower motor neuron, distal, asymmetrical to start with fasciculations, LMN and UMN, there is only one diagnosis. It could be an anterior console disease. Yes. So anterior console disease at the bedside is classified as purely LMN, purely UMN, LMN plus UMN. But in this age group, if it is UMN, because we are blind, we don't know whether it's LMN or UMN. If you think it is UMN, all those DDs you have to consider. CVG anomaly, medial medullary artery syndrome, which is called ventral bulbar syndrome of Digerin. Or then you may have brainstem tumors, foramen magnum tumors, no? And vascular pseudobulbar.
Okay. Yes.
Supposing it is all LMN, then the possibility becomes anterior console disease, which are classified as purely LMN, under which you have got progressive bulbar palsy, progressive muscular atrophy. And purely UMN, you are having ALS, primary lateral sclerosis. And LMN plus UMN is classically is ALS.
Yes.
And purely UMN will be primary lateral sclerosis and pseudobulbar palsy.
Yes.
Pseudobulbar palsy and primary lateral sclerosis is purely UMN. Progressive bulbar palsy and progressive muscular atrophy
LMN.
is purely LMN. ALS is LMN plus UMN. So if you think that your patient has only LMN in the lower limb and UMN in the speech, then it will qualify for ALS. So now I want you to, considering 72 years, before we go into your examination, then I want you to differentiate vascular pseudobulbar from degenerative pseudobulbar. You know that pseudobulbar palsy is a type of upper motor neuron type of anterior console. No. And you have got a vascular pseudobulbar. How are you going to differentiate both?
Vascular will be acute in onset, but this patient had a long
Agreed. So it may be acute and step-like. So so many episodes came together in a step-like fashion. One came stabilized, another came stabilized. So acute onset step-like progression is a feature of vascular pseudobulbar, whereas slow onset steady progression is a feature of degenerative. Agreed. Second. But sometimes vascular, if it is a small vessel disease, it will behave like a degenerative disease. Small vessel disease. Large vessel disease only will show the acute and step-like, whereas small vessel disease will be slow and progressive. So it can closely resemble, because prognosis is different. If it's a vascular pseudobulbar, still patient can expect something. If it is a degenerative pseudobulbar, there is nothing to expect. No.
Yes, ma'am.
So then, next point.
Associated weakness
Fibrillation. You said fibrillation, fasciculation. No.
Fasciculation.
Presence of fibrillation and fasciculation is favoring a degenerative. These are not seen in vascular pseudobulbar.
Yes, ma'am.
You see, even degenerative pseudobulbar can have significant stiffness in the limbs. It does not exclude ALS. Limbs need not be always LMN. It can have stiffness. No.
Yes,
So
ma'am.
that will closely resemble. But if there are fibrillation and fasciculation, it is degenerative. In
Yes, ma'am.
vascular, you don't find it. Third point, pseudobulbar laughter and crying
Yes.
is more common in vascular because vascular is again non-selective. Like I told in the lower motor neuron, you have got a motor unit pattern
Yes,
in
ma'am.
the element, whereas motor root pattern in the root. For the root is the motor root pattern, whereas motor unit pattern for anterior console. Similarly, same thing happens in the upper motor neuron also. There is selectivity. Because of that, patient will have a spastic speech. There may be nasal twang. You do the palatal gag reflex, it is brisk. So it is pseudobulbar palsy. But the pseudobulbar crying and laughter may not be dominant. So dementia may not be dominant. So dementia is not dominant, and pseudobulbar laughter and crying is not dominant in degenerative. But they are equally dominant in vascular. So 3 points: acute onset and step-like is favoring vascular, steady progression is favoring degeneration, presence of fibrillation, fasciculation favors degeneration. They are not seen in vascular, and the affective component is more affected in vascular, whereas they are not that much affected in degenerative. Whereas asymmetry is common to both, so that doesn't help you. So now, considering all these features, it is closer to degenerative, steady, distal, so LMN plus UMN, probably it is a ALS from the history. No?
Yes, ma'am.
So you'll go to, but always rule out a treatable cause. Always look for the least possibility of a treatable cause, keeping it in mind. That is why I discuss all the differential diagnosis. Okay, go on.
Yes, ma'am. General physical examination. Patient is conscious, cooperative, oriented, poorly built and nourished, BMI 16 kg per meter square, and no pallor, icterus, sinuses, clubbing or lymphadenopathy and edema. Vitals, pulse rate was 74 beats per minute, regular rhythm, normal character, good volume, no vessel wall thickening, no radial or no radiofemoral delay. Peripheral pulses are well felt. Blood pressure 130 by 80 in the right arm supine position, in left arm 126 by 80. Respiratory rate 25 cycles per minute, thoraco-abdominal type of breathing. Saturation is 94% room air. No peripheral.
Thoraco-abdominal means what, ma? What is the normal male pattern respiration?
Thoraco-abdominal.
Male pattern, male pattern.
Abdominothoracic.
Abdominothoracic. Male pattern is abdominothoracic.
Thoracic.
So there is reversal. It has become thoraco-abdominal. That means which muscle is affected? Diaphragm.
Oblique.
Diaphragm. No?
Diaphragm.
Thoracic is moving better. That means intercostal muscles are better.
Yes.
So reversal of the respiratory rhythm in the male to thoraco-abdominal indicates that his diaphragm is more affected. Okay. That is why the intercostals are expanding the chest, but diaphragm is not expanding the abdomen. Yes. So the respiration has become thoraco-abdominal. So diaphragmatic muscles are seem to be more involved in this case. Okay, then.
No peripheral thickened nerves seen, ma'am. No markers of atherosclerosis or cutaneous markers. CNS examination, hair mental functions, ma'am. Conscious, oriented to time, place, person. Speech and language actually could not, he was able to speak with the help of the speaking valve which was attached to tracheostomy port, ma'am. So, and memory was not intact, ma'am. Cranial nerves, normal, ma'am.
Tongue. What about tongue?
Tongue, we could see there was fibrillations were present.
Was it atrophy? Was there any atrophy?
Yes, ma'am. Atrophy.
Was it spastic or flaccid?
It was flaccid, ma'am.
Okay. Gag reflex. Did you elicit gag reflex?
Yes, ma'am. Gag was present, ma'am.
Present. So that
Present.
means it is even element gag can be present, because as I told,
Yes,
unlike the other kinds of element like oculopharyngeal myopathy, if it is an oculopharyngeal myopathy, you expect the gag to go. Whereas in anterior console disease, gag can be present, even if it is human. Did you record the speech, ma? The speech is not there, no, for me to hear and see whether it is human or element.
didn't record, ma'am.
Okay. Next time, some of the things we'll try to demonstrate,
Yes,
so
ma'am.
that we will see whether it is what exactly it is. Then
Okay, ma'am. Okay. Motor
tell me.
system, attitude, supine position, extension in the both hip and knee joint, plantar flexion at the both ankle joint, and there was a muscle wasting was there, ma'am. At and the bulk was actually there was a wasting, ma'am. Right more than left, right arm more than left, and all over the muscles there was a wasting was there, ma'am, and tone increased in all four limbs, ma'am. And the power, ma'am, shoulder flexion, extension, adduction, abduction. There was 3 minus by 5, and elbow and wrist, elbow flexion and extension 2 by 5, wrist flexion and extension 2 by 5, and there was weak hand grip was there both sides. Hip, lower limb, ma'am, hip flexion, extension, abduction, adduction. There was 1 by 5, ma'am, both side. Knee flexion, extension 1 by 5. Ankle dorsiflexion and plantar flexion 1 by 5, ma'am. Extensor hallucis longus flexion and extension 1 by 5. And the involuntary movements were the fasciculations, and gait we could not assess, ma'am. Superficial reflexes, corneal reflex was present and plantar was absent, ma'am. Dip tendon reflexes, ma'am.
Plantar is absent because you hardly have any movement in those muscles. So even if it is upper motor extensor, nothing you can elicit. Abdominal reflex is absent. So in this context, what you should do, ma'am? You want to know whether it's element or human, you should elicit the deep abdominal reflex, because spastic speech you told. So you should look for other evidences for upper motor neuron involvement. So element weakness, both superficial and deep abdominal reflex will be absent. In human weakness, the superficial abdominal reflex will be absent. Deep abdominal reflex will be present. So that will help us to know whether there is an upper motor involvement contributing to the abdominal reflex. So some signs of, you can look at the jaw jerk. Gag reflex is not going to help you to differentiate. Even pure element gag will be preserved in anticonceptual disease. So we don't know. But if it is absent, it will help us. If it is present, it's not going to help. Jaw jerk will help. And superficial abdominal and deep abdominal reflex will help. Plantar will not help because the muscles have no power to extend or flex. So it will not show plantar. Okay. Then other reflexes, they are good.
Reflexes.
They are all
upper limb
that
biceps
is indicating an upper motor neuron component.
Yes, ma'am.
Spastic speech and such weak muscles showing 3+ reflex is an upper motor neuron component.
Yes,
if you have elicited the jaw jerk as well as you have elicited the deep abdominal reflex, it would have been a very good point for you. Okay, go next.
Sensory system was intact, ma'am. Cerebellar system could not. No meningeal signs. Skull and spine was normal. No deformity or scar at the vertebral level.
So after examination, you did not find posterior column involvement. No. So it is not a ventral bulbar syndrome of Dejerin. You did not find any evidence for restricted neck movement. So you did not find painful restriction of neck activity. So it's less likely to be craniovertebral junction. And in the lower limbs, everywhere it is lower element with retained reflex. So element. So this diagnosis in your case is straightforward, but you should not miss a similar case of other etiology. That is why you have to do symptom analysis. A given case may be easy diagnosis, but another disease masquerading like an MND, you diagnose MND means it is a fatal diagnosis. So fatal diagnosis should be the last one. No? So you should always remember an elderly person. It can be CVJ, it can be vascular pseudobulbar, it can be ventral bulbar syndrome. No, all these things you should keep in your mind. In your case, it looks like straightforward because so much element with very well elicited reflex.
Yes, ma'am.
And no bladder, no bowel,
Good.
and there is no sensation at all, including posterior column. So
Yes.
it looks like a degenerative disease. But okay, next you go. Why did he develop acute respiratory distress? Most probably he would have aspirated.
Yes, ma'am.
Otherwise, even diaphragmatic paralysis, they can manage with a without diaphragm will resemble cardiac failure. Yes, diaphragmatic paralysis will produce paroxysmal nocturnal dyspnea. So you will think cardiac failure because when you lie down, the diaphragm goes up. So patient will develop nocturnal dyspnea. It can be mistaken like that. That history you did not tell. But did he have any aspiration?
Yes, ma'am. He had aspiration, ma'am.
That may be the cause for acute deterioration.
Yes.
But okay. So you had the diagnosis of MND.
Yes, ma'am.
Why there is crying and laughing? I will tell you, ma. So you see, why this tracheostomy? Because if you know the diagnosis as MND, the law tells you not to do tracheostomy, not to connect you to the ventilator. You see, because it is torture for the patient to have a hole in the neck and die. Better to die without a hole in the neck. The law protects you. If you know the diagnosis as MND,
Okay.
then you should not ventilate the patient.
Yes.
Because it is torture. He is a teacher. He will know. He may want to sing Narayaniam and die. You see, the very highly teachers are very great people. They are altruistic and unselfish, and they know what to do with their life when it becomes no more useful to the world. So law protects you from doing a tracheostomy or ventilatory support because it is a point of no return. If you do not know the diagnosis and patient presented with acute pneumonia and you are still investigating to know whether he has a CVJ anomaly, you can do tracheostomy. Otherwise, you examine the patient, diagnosis straightforward. I think it is straightforward. In that situation, you should not do. So this is a masterly inactivity, we tell. Some situation, you have to apply masterly skill to be inactive.
Yes.
To have a stick in the neck is more than death. No?
Yes,
so that should not happen. And legally you are protected. You are not supposed to do that. Okay, doesn't matter. Somebody asked me what is, why there is no crying and laughing in pseudobulbar. You see, in pseudobulbar of vascular nature or whatever nature, it is the corticobulbar fibers which come from the motor cortex to the brainstem motor nuclei. So motor cortex to the brainstem motor nuclei alone degenerate in degenerative pseudobulbar in the initial stage. Or if you can have some combination, FTD-ALS, those syndromes are different. The classical degenerative anterior cell disease, it is the corticobulbar fibers from the motor cortex to the bulbar motor cranial nerve that degenerate. So it is only purely motor pseudobulbar. So you have a spastic speech, you have bulbar weakness and strong gag reflex. That is the degenerative pseudobulbar. Whereas in the vascular pseudobulbar, it is not just the motor cortex. It is the premotor, prefrontal, all those areas. It is a ACA territory or the MCA branches which supplies the posterior part of the frontal lobe or multiple small vessels. That is non-selective. It involves the frontal lobe. So not only the motor cortex, frontal lobe to the brainstem structures. What does the frontal lobe does to the other areas? There is frontal monitoring of limbic function. Limbic function means it includes care for the young one, love for the young one, laughter, smiling, everything is a limbic function. So frontal lobe monitors our limbic functions. That is why we don't go and laugh with the strangers. We do not cry and share our emotions with people who are cold to us. We share it with someone who will give you a shoulder. So that is called frontal monitoring of limbic function. In vascular pseudobulbar, it is non-selective frontal lobe involvement. So not only the motor cortex to the bulbar functions that are affected, it is a frontal monitoring of the limbic function is also affected. So you are unable to control your crying, you are unable to control your laughter, You cry without stimuli, laugh without stimuli, cry with strangers, laugh with people who laugh at you. You see, that is because in vascular it is non-selective. It affects the motor cortex to the bulbar motor nuclei, resulting in swallowing difficulty and spastic speech, and prefrontal region controlling the monitoring of the limbic functions. Frontal monitoring of the limbic expression in the social setting is also affected because it is non-selective. So the person will laugh and cry without concern for the one who is listening to you. Is he your loved one? Will he understand your emotion? That you are not knowing. So you will cry and laugh without appropriate stimuli, without an appropriate person. That is why there is laughing and crying unmonitored, unstimulated, with unacceptive environment in vascular. Whereas in degenerative, those frontal areas are not affected. Only the motor cortex to the bulbar nuclei is affected. So there is only spastic speech, swallowing defect. As the disease advances, you know that there is ALS FTD complex. As the disease advances, frontal lobe also degenerate. At that end stage, they can have pseudobulbar laughter and crying also. Understood, ma? Is my answer clear?
Yes, ma'am.
Any other question? Any other question, ma?
No.
Is this answer clear, ma? If anybody did not understand, you can ask me. Frontal lobe is not just a motor lobe. Frontal lobe has got a precentral motor strip, but rest of it is behavior and limbic functions. So frontal monitoring of the limbic function is another function of the frontal lobe. Because of the non-selective involvement in vascular, that also goes. That is why you laugh and cry. Okay, this is a wasted hand, wasted leg, agreed. Show me, anything else is there? Tongue is there?
I have a video, ma'am.
Show. Show the video. Video is there?
Yeah, it's there.
Then show me.
1 second. It's not able to play, ma'am, here.
Okay, no problem. Any other doubt, ma? So if you want to tell etiology.
Just 1 second, ma'am. I got the video. I'll just share it in a minute.
Sure. Meanwhile, you can say that cause of these diseases, we say inherited superoxide dismutase happens in young onset MND. Late onset can be paraneoplastic. This person progress very rapidly. So you'll have to look for paraneoplastic. Sometimes chronic organophosphorus compound poisoning, heavy metal poisoning. Then you have got acquired superoxide dismutase deficiency resulting in oxidative stress. Then some other postulates are slow virus diseases and again immune mediated. So these are the, in young people, it is superoxide dismutase deficiency. Rapidly progressive Andrew-Hansel, you should always look for paraneoplastic syndrome. Then heavy metals like mercury is incorporated, slow organophosphorus, then oxidative stress, and immune mediated possibility has been postulated by a post-mortem analysis of spinal cord of these patients, where people found that there is accumulation of immune complexes. So in some centers, especially popularized by NIMHANS by Professor Gauri Devi, use of cyclophosphamide, but it did not show any long-standing benefit, though, so it has been removed. That was based on spinal cord post-mortem analysis where people found immune complex. Then people have used antiviral agents because of the slow virus possibility. Now we see that sometimes MND and myasthenia coexist. So the possibility of a other immunological like acetylcholine receptor antibody, like antibody mediated possibilities are also being considered. So immunotherapy including IVIG is being tried. So oxidative stress you treat with antioxidants, and you have got riluzole is a strong antioxidant. Cyclophosphamide was tried suspecting the possibility of based on the seeing of immune complexes, and then plasmapheresis IVIG based on the new syndromes of myasthenia and MND coexisting. All those things are there, but as I have told, riluzole is supposed to delay the ventilatory stage of the patient by 3 months. That is all. Whether it is significant or not, we do not know. And this is one disease where the rule forbids that you intubate or do any massive restorative procedures, because a conscious patient will struggle with his life. No?
Yes.
Okay. It's an atrophic tongue with a central depression, and definitely fibrillations are there. It is very much visible. Did you look for any occult malignancy, ma'am? No?
Yes, ma'am. Like, no, it was not there.
Okay. Yes, too rapid. You said that within 1 year he became like this.
Yes, ma'am.
Indian ALS study says that people live up to 11 years. No? So this is very rapid progression. Some kind of tremulousness is there in the limbs, I think.
Yes.
Okay, so it's a straightforward, but only thing is too rapid, because Indian ALS has got a slower progression than Western ALS, and they live much, much longer. So what made it very fast? That is the only odd thing. So we'll have to, even though he is end-stage disease, paraneoplastic antibodies, some occult malignancy somewhere, you'll have to rule out because it is too rapid. Indian ALS study done by some people in NIMHANS only, and that is published. It shows that they live up to 11 to 12 years. No? So this is very rapid.
Okay.
That is the only feature which need to be addressed in this patient. Any other question, ma? Any other question? No. Okay, you these are straightforward cases, but I have repeated some of the points which discussed before, and each symptom you are presenting, I am teaching you how to analyze, so that any other case which is a close imitator will not be missed.
Yes.
That is why that is how I am planning, because you know that more number of doctors are developed for manpower development of rural India. That is the aim of the government, to develop manpower for rural India. You should not ask that I want 5 Tesla, 7 Tesla MRI everywhere, then only I will diagnose. And MRIs are much inferior computers compared to your computer, provided you consider your life as a submission to Almighty.
Yes.
That is the thing. People will beat us, they will hit us, because the society consists of all kinds of people. But we cannot degrade ourselves like that. We will sustain our contract with Almighty, so that our Janma becomes Punya.
Yes.
Thank you so much, ma'am.
Thanks a lot, ma'am.
Thank you. Thank you all. Any other doubt is there, I will answer. Anything? No?
No, ma'am.
So should we close now?
Yes, ma'am. It was indeed a comprehensive clinical class. Thank you, Professor Chandra, ma'am, for the wonderful discussion and your valuable inputs, ma'am. Thank you, Dr. Sachin, for the amazing presentation. We could learn a lot from it. Thank you all the participants for your active participation. Thank you one and all.
Thank you.